of how hormones are produced, how they are acting, and how they have unique features in terms of action from that perspective. And we also discussed what can cause different endocrine disorders in that regard. So today we'll continue that, and we'll use case scenarios to highlight that aspect as well. There are distinct release patterns which make it important to emphasize, and we discussed this when we were discussing about the diagnostic purposes. So we know that many hormones are pulsatile in nature. So which ones are pulsatile? Very importantly, which we need to be aware about. So growth hormone, of course. So single value of growth hormone has got no diagnostic value. What else? GnRH, but we don't measure GnRH. So anything else? So something linked to GnRH? Gonadotrophins, prolactin. So these all hormones will be having a pulsatile nature. So we've discussed about growth hormone, gonadotrophin, prolactin, cortisol, and testosterone. Now, how do we make sure that we are not missing these pulses? That when we are doing a test, we are doing it at a nadir time. So how can you ensure that you don't miss them?
We can do a stimulation test or a
Okay.
pooled, sample.
Yes, you can do a pooled sample in which you take 3 levels, maybe 0, 15, 30 minutes, and then you can do pooling of that and get the right result. So most commonly we do that for prolactin, for testosterone, and for gonadotrophins, because stimulation test requires more expense, requires more process. So maybe if you do a good basin sample, you may be able to identify that from that regards. Then we also have diurnal variation, and this is the classical diurnal variation of cortisol. What we see is that when we wake up, we need the maximum amount of stress hormone. The levels are highest. When we are sleeping, the level should be low. So this will be important when we are looking at. So if you want to diagnose cortisol deficiency, what time of the day should the sample be taken?
Morning.
So when it is highest. And when you want to diagnose excess, you want when the levels are lowest. So if it is high during the time when it is low, it is significant. When it is low, when it should be high, also it is significant. So that is something becomes important. So many of them have a diurnal variation. I already talked about cortisol, but ACTH, of course, we also talk about a morning ACTH sample. Growth hormone, estradiol have a diurnal rhythm. Then many of these reproductive hormones in females will definitely have distinct action, and this becomes important. So when you want to do what test becomes relevant. So that will include a number of hormones like LH, FSH, 17, or estrogen, progesterone. Now, most hormones we would like to assess at day 2 to 5 of menstrual cycle, be it LH, FSH, testosterone. But there could be one hormone which is assessed at a later stage. Which one is that?
Progesterone.
So when would you like to do progesterone?
21.
So day 21, 1 week from ovulation is when you want to look at, because it is a marker whether corpus luteum is there or not. So that is how you will detect that from that perspective. Now, can you do testosterone at levels other than day 2 to day 5? Suppose somebody comes to you, it's around day 10 of periods. Will you do LHFSH first of all? No, yes or no?
No.
Why?
Because at that particular time, we are expecting that levels should be going higher actually. So we
Yes.
have to do at a point of time when the levels should be on the lower.
So that becomes important. Now, from that perspective, you will like to do the testosterone levels. Can you do it on that day as well or not?
Day 10, we can.
Day 14?
No, we don't want.
Why?
Because at that particular day, we are expecting that levels should be much more higher.
So if the level is normal, then you are not worried. If the level is normal, you are not worried. But if the level is high, then you repeat it day 2 to 5. So this is something we need to understand. So when the level is supposed to be high, highest, even then the level is normal, it basically means that you don't need to bother about that. But suppose if it is high, I would like to confirm it day 2 to 5. Same with prolactin also becomes relevant from that regards. And there are seasonal variations. Which hormones have a seasonal variation we discussed a couple of weeks ago? So thyroid clearly has, because when you have winters, you want thyroid hormones to be more. When it is summer, you want them to be less. Then vitamin D, because of the effect of the season, not because of the season per se. And many of these reproductive hormones we know have a definite seasonal variation, whether it's estrogen, prolactin, or testosterone. So these are the ones you have to look into. So same person, I've seen patients who are on a stable dose of thyroxine. During winters, their TSH goes up because their requirements are going up. So this is something you need to be aware about. Now, problems in release can also cause multiple disorders. So we know that two hormones which are stored in the body in a large quantity are AVP in the posterior pituitary, and the other one is thyroid in the thyroid gland. So if you have damage to those glands, you may cause too much excess. So release problems can cause problems in terms of DI and SIADH both. So initially it will cause SIADH and then it will cause DI. If the thyroid is damaged, you will have a transient thyrotoxicosis, which we see with subacute thyroiditis, with other forms of thyroiditis as well. And of course, the problems could be in the form of insulin is not being released. You will have neonatal diabetes, or too much is being secreted, that will become hyperinsulinism. And this is what is dependent upon the ATP levels and interpretation of ATP levels. So, what is the major determinant of insulin secretion? So when does the beta cell tell want or wants to secrete, and when does it want to stop insulin secretion? So when would you like your insulin to be high? When your glucose is high, or if you put it in a more, what does insulin do? What is the major role if you want to do one part? What is insulin's role?
It decreases the blood,
So,
increases the glucose level.
anything else? It is using the energy to build up things. So it's an anabolic hormone. So when your energy levels are high, insulin should be high. That is it. Now that energy may be coming from glucose. It may actually be coming from proteins, from fat. So ATP is the predominant intracellular regulator of your insulin secretion. And that ATP has binding with the potassium ATP channel. Now, if your potassium ATP channel is hyperactive, you will have
If it is hyperactive,
you will have
no insulin secretion.
you will have diabetes. If it is underactive, you will have too much insulin secretion, you will have hypoglycemia. So both ways it will be working from that regards. And of course, release, we discussed about how PTH is regulated by the magnesium pathway from that regards. Now, insulin, we'll all talk about insulin much more in detail when we talk about diabetes and hypoglycemia. But just to put the point, the major regulator of insulin secretion is the ATP. If your ATP is high, insulin is there. ATP is low, no insulin is there. So in a way, body is telling, now I've got more energy, you store it. I've got more money, you put it in the bank. This is what insulin is being told. Now, this basically can come via the glucokinase, GLUT2 pathway, the amino acid, and the fatty acid, the DDH pathway in that regard. So this ATP is going to act on the potassium channel, which has got the two subunits, the potassium subunit and the sulfonylurea subunit, to cause insulin secretion. So if you have a problem there, you may secrete more insulin, causing hyperinsulinemic hypoglycemia. If you have too little, you will have less insulin, causing diabetes. So we have got ABCC8 mutation, which on one hand is going to cause both hypoglycemia as well as diabetes both, and that is something which will happen. So you can have both hypoglycemia and hyperglycemia depending upon the nature of the defect which is there. So we have a 3-day-old boy with severe hypoglycemia. Birth weight is 4,600 grams. GIR is 18. What is your clinical diagnosis? No, clinical, just based upon this information.
Could be a hyperinsulinemia.
So this is hyperinsulinemia. Is it prolonged hyperinsulinemia? Is it inherited form? It is IDM? What do you think?
Be a prolonged hyperinsulinemia. GIR requirement is not.
So generally the prolonged one usually will have not LGA. So macrosomia is a big pointer. So it could be IDM, or because they say it could very well be IDM, or it could be a form of a potassium ATP channel defect as well. Now there is non-ketotic hypoglycemia. Insulin is 2.4, so it is detectable. What is now your clinical diagnosis? So hyperinsulinism, most likely because of some of these forms which cause macrosomia, potassium ATP channel defect, and they will respond to diazoxide. 2-month-old boy with failure to thrive. Birth weight is 2500 grams, weight is not increasing, has got liver enlargement, muscular weakness, and myopathy, has got diabetes. So, which genetic defect can cause this diabetes? And we discussed the same, that the same potassium ATP channel defect, if it is having a activating form, will cause this diabetes. If it's inactivating, you can have hypoglycemia. So again, it's majorly a problem of insulin release rather than that. And we have patients with ABCC8 who have everything. They have diabetes which is late onset, we have seen diabetes which is early onset, and we have seen persistent hypoglycemia. So same defect can present in different forms. Now, PTH, we already discussed. The PTH release is regulated via a number of factors. The major factor, of course, here is the level of magnesium. If you have hypomagnesemia or hypermagnesemia, both of them are going to impair the PTH release. How does hypermagnesemia decrease PTH?
Actually mimics the acts on the calcium sensing receptor, mimics like calcium.
So magnesium and calcium are structurally similar. So they will act on the calcium sensing receptor. Body will say, okay, I've got more calcium, so your PTH should go down, and you will in that case have hypocalcemia with hypercalciuria. So 10-year-old boy, Alappan, seizures, ionic calcium is 2.1, phosphorus is 4.4, PTH is 12. What do you think? Is this hypoparathyroidism?
The calcium level is low while having seizure. Phosphate level is not correlating with the PTH. PTH, if it is hyperthyroidism, the phosphate level should be higher.
So this is hypoparathyroidism, you can definitely say. But now, whether it is a true hypoparathyroidism or something else is causing this hypoparathyroidism is the question. Because if your calcium is low and your PTH is low, it is hypoparathyroidism. But is it a reversible form of hypoparathyroidism? That will be your point. So what should you do here? And if I say the child also has hypokalemia, there is metabolic alkalosis. So hypocalcemia, hypokalemia, metabolic alkalosis with hypoparathyroidism. What will you do? What can cause PTH to go down? Magnesium. So you should definitely look at the magnesium level. So before you label anybody with hypoparathyroidism, you have to look at magnesium levels. That's what we were discussing in that case also, whom we saw yesterday in the similar scenario. So magnesium becomes important in that perspective. Usually, now this is interesting and this is important, you will get. Now, why is there no hyperphosphatemia here? You said that if PTH is low, you should have hyperphosphatemia. So why is this child not having hyperphosphatemia?
IV calcium has been given to gradually.
No? Anything more logical? What is the impact of magnesium on phosphorus? If you have low magnesium, what are the three major intracellular ions? Magnesium, potassium, and phosphate. One is deficient, the other is also deficient. So when we already discussed, so if you have refractory hypophosphatemia, refractory hypocalcemia, everywhere magnesium becomes important. So here PTH is dragging it up, but the magnesium deficiency is dragging it down. So that's why phosphorus is nowhere. It's neither low, neither high. But this is an important parameter. The question often will ask is whether the PTH deficiency is causing hypomagnesemia or hypomagnesemia is causing PTH deficiency. The answer is PTH is phosphorus. If your phosphorus is very high, you say it's primarily hypoparathyroidism. If phosphorus is not that high, it is primarily hypomagnesemia. And this is what we saw in a younger child with a TRMP defect.